I'm Matthew Weinstock with Hospitals and Health Networks with continuing coverage from Phoenix at the Rural Healthcare Leadership Conference. I'm joined right now by Tom Morris, Associate Administrator for Rural Health Policy at the Health Resources and Services Administration, part of HHS. Tom, thanks for being with me.
Oh, thanks for allowing me to be here, Mike.
So Tom, earlier this morning you were on a panel that talked about some of the realities of rural healthcare and the finances impacting rural communities. There's some new research out there from the University of North Carolina, particularly on critical access hospitals. Can you give us a sense of what kind of finances they're facing right now and what the structure is for them?
Sure. Yeah, I mean, I think it's a real mixed picture. There are some areas of the country where the CHs are doing quite well financially, and then there are some areas where the financial indicators don't look as good. And they're driven by a variety of factors. A lot of it may be related to some of the private insurance rates they get. Some of it may be related to the Medicaid rates in those states, and there may be other market characteristics, that are affecting that. I guess the takeaway really is that you can't necessarily make a general statement that all CHs are facing this situation or they're all financially healthy. You really have to drill down at the regional and the state level and then dive into the factors that are driving it.
So Tom, another theme that's really developed here at the meeting is that move from volume to value and where rurals fit into that environment. Can you talk a little bit about what you're seeing in that area and what HRSA has been doing to sort of help hospitals along that way?
I think what we're trying to do is put our resources out there and align it to people to start them to think about quality. So we have about $50 million a year in community-based grants that we put out there. A lot of that could be focused on quality. A lot of that could be focused on training and coordinating care, all of which I think will position folks to be ready for when the switch flips and the payment is based solely on that outcome and that value. Similarly, on the hospital side, we run the Rural Hospital Flexibility and the Small Hospital Improvement Grant programs, and we're really trying to focus very tightly on performance improvement and quality improvement and looking at metrics that make sense for those particular facilities, because the things you measure in a small rural hospital may not be the same things you measure in a large academic health center. And we've seen some pretty good indicators so far. We have more hospitals reporting on quality, and I think if you measure them on what they do, they can do pretty well.
The Centers for Medicare and Medicaid Services, the Innovation Center within the agency, has issued several grants to rural communities. Can you talk about what those grants are and what kind of results you've seen from them so far?
Yeah, I think we're still in the early stages as far as results, but through their Innovation Challenge, we were real pleased that a number of the folks that got awarded were from rural communities, and they're testing out a number of things, from using community health workers to health coaches. We're seeing folks use like home monitoring equipment, things like that. I think over the next couple of years, probably the next 2 years, we'll start to see the data come out of that. And I know CMS is really interested in turning that around. But perhaps the best demonstration for rural is the one that got announced last week, and that's the Frontier Community Health Integration Program demonstration focused on patient care and coordination in low-volume frontier environments where the CH is sort of the centerpiece of care. And I think within the next couple of years, we'll really have some interesting findings from that.
Great, and Tom, I want to ask you one question on the policy front. As you know, rural hospitals have been particularly concerned about the direct supervision rule that's out there. What have you heard from them? What are you doing in terms of talking to CMS about maybe making some modifications to that, if there are any?
Yeah, we've worked with CMS real closely on this. I know there's a fair bit of anxiety out there among folks about what that might do to access and whether they'll still be able to offer some of those therapy services. I think CMS has a good process in place where folks can present to their outpatient panel and make the case for why a certain service may not need direct supervision. We did work with them early on when it was first announced, and some of the recommendations that we convened from a panel were adopted by CMS. So I think over the next couple of years, we're going to continue to try to put some of our policy and research resources into looking at procedure by procedure, which ones need that direct supervision and which ones don't. Share that information with CMS. I think that now that the moratorium is lifted, we'll start to see what the impact is. Is access affected? Can we do a service where it's still safe for the patient, and a high quality? It's going to play out in the next couple of years, but I think a process is in place to do that, and so we'll see where that goes.
Great. Well, Tom, I appreciate your time today.
Thank you so much.
And I'm Matthew Weinstock with HNHN. Be sure to see our concluding coverage of the Health Forum AHA Rural Healthcare Leadership Conference in tomorrow's HNHN Daily. Thanks for tuning in.